Good morning. Thank you for joining us for this week virtual journal club. I'm J.P. Britton, endocrinologist at Mayo Clinic and co-host of this series. Today, we're going to delve into the intriguing realm of patient and clinician role in the thyroid cancer care. And for that, we are delighted to have Dr. Haymart with us. Dr. Haymart is the Nancy Wigginton Endocrinology Research Professor in Thyroid Cancer and Professor of Medicine at University of Michigan. Dr. Haymart received her medical degree from Johns Hopkins University School of Medicine in 2002 and completed residency in the same institution in 2005. Then Dr. Haymart moved to Michigan to complete the University of Wisconsin to complete the endocrine fellowship. Dr. Haymart is involved in creating the National Comprehensive Cancer Network, Thyroid Carcinoma Guidelines, and the upcoming ATA Adult Differentiated Thyroid Cancer Guidelines. She serves on the editorial board of the Journal of Clinical Endocrinology, Clinical Oncology, Clinical Endocrinology, and associate editor of the Thyroid Journal. She has previously served in the board of directors for the American Thyroid Association, clinical science chair for the Endocrine Society Annual Meeting Steering Committee, and the president of the Women in Thyroidology for the ATA. Dr. Haymart has a history of NIH-funded research focused on optimizing cancer delivery and understanding and addressing thyroid cancer overdiagnosis or treatment. And I would like to add, Dr. Haymart is one of the most influential researchers in thyroid healthcare delivery. So it's really a pleasure to have you, Megan. Thank you very much.
Thank you so much for that kind introduction, and it is such a pleasure to be here. So I'm going to talk today about understanding the role of the patient and the physician in thyroid cancer care. And just as a disclosure, a lot of this will be focused on my team's research. This is something that's been of great interest to us, and especially the interplay between the patients and the physicians. And so we're going to talk about the cancer care continuum from diagnosis to management to survivorship, again, focusing on the patient and the physician. I have nothing to disclose. We're going to start with the patient, and the patient, as we all know, is central to what we do as physicians. And it's important to really understand the patient's perspective. And so what we wanted to do was take a deep dive. So our team has previously used a lot of big databases to look at outcomes, but we wanted to understand more from the patients and their perspective. And so we had funding from the NIH. And with that funding, we surveyed patients with differentiated thyroid cancer who were diagnosed between January 2014 and December 2015. These were individuals affiliated with LA County and then the state of Georgia. And we specifically picked these two regions because we wanted a lot of diversity. That with the SEER registries, we already get rich information on thyroid cancer pathology, the initial treatment, but through surveys, we could find out more about patient-reported outcomes. And so we were able to link the surveys to the SEER data, giving us a depth of information about the patients. We focused on adults, and again in LA County and the state of Georgia. And so we sampled these individuals and we used the modified Dillman survey response. And so what we would do is we had an initial mailing with a cover letter and a small gift, and then there would be phone call follow-up in addition to subsequent mailings. And this phone call follow-up was done in both English and Spanish in LA, since there's a large Hispanic cohort. We were very happy. We ended up with a 63% response rate. And so just to put that in perspective, just published in JAMA, you have to have above a 60%. So this was a robust response rate that we were really happy with. And our cohort, as you can see, is reflective of what you might think a thyroid cancer patient cohort would be. So we had over 2,600 patients. The mean age was 50, and if you look at the population at large within the US, the mean age of patients diagnosed with thyroid cancer is 50 to 51. 77% of our cohort was female. Again, if you look across the US, about 75% are female. We did have a more diverse cohort, and this was deliberate. So 57% were non-Hispanic white, 20% Hispanic, 11% Black, 9% Asian, 2% other. And then what you'd expect with thyroid cancer, 69%, so a very large percent, had stage 1 disease with AJCC SEER staging, 8% stage 2, 15% stage 3, 6% stage 4, and 1% was unknown. Again, similar to what you'd expect, 93% were papillary thyroid cancer. So this cohort was very representative of thyroid cancer in the United States, with the exception of the fact that it's more of a diverse cohort, which was deliberate. And we asked the patients about their cancer care from diagnosis to management to treatment or to survivorship. And so I want to focus first on diagnosis. So we wanted to know from the patients, how was your cancer diagnosed? And so we specifically wanted to know about individuals who had cancers less than a centimeter versus greater than a centimeter. And the reason that we were interested in this is, as you may know, about a third of all thyroid cancers are less than or equal to a centimeter. Technically, the guidelines say that individuals with cancers these small, unless they have lymph node mets, of course, should not have biopsies. So what's the pathway that is leading to patients being diagnosed with these papillary thyroid microcarcinomas? So we started with our cohort of 2,632. We excluded those who had no surgery or surgery was unknown, that the tumor size was unknown, or if the stage was unknown. And so we ended up with 2,563. And we asked the patients how their nodule was detected. And so what you can see from this bar graph here, so doctors feeling it was about the same for large tumors and small tumors. And so somewhat that seems surprising, but then again, if you work in an FNA clinic, or if you see patients that are referred to for nodules that are palpated, sometimes you'll realize that other things are palpated that are not actually nodules. If the patient felt it, it was more likely to be a larger tumor. And then you can see if it was detected with thyroid ultrasound, it was more likely to be a small tumor, so less than a centimeter. And then you can see we have this plot over here, this forest plot. And what you can see is, again, when we did the multivariable analysis, what was associated with these small tumors. So if it was picked up by ultrasound, more likely to have a small tumor. You can see the older patients more likely to have a small tumor. And Hispanic and Asian patients compared to non-Hispanic white, less likely to have these microcarcinomas picked up. And so again, just emphasizing the fact that thyroid ultrasound is leading to the diagnosis of these small thyroid cancers, or at least contributing. So when we looked at diagnosis, we found that thyroid microcarcinomas are more likely to be detected with ultrasound when we ask patient report. And this is very similar to what you'll see if you do big data analysis as well. So ultrasound's contributing to the diagnosis of thyroid cancer, especially microcarcinomas. And understanding these diagnostic pathways will allow for targeted interventions to decrease this overdiagnosis and overtreatment. We then asked the patient about their management decisions. And this was actually what our grant was funded for. So we wrote this really large survey that was very comprehensive. The grant itself was focused on diagnosis, or was focused on management and decision-making. So one of the key things we wanted to know is about shared decision-making. And so these individuals were diagnosed in 2014 to 2015. And so the guidelines that were in play at that time from the ATA were the 2009 guidelines. And in these guidelines, there were certain cohorts where radioactive iodine was not recommended. So if you had a gross extrathyroidal extension, or sorry, if radioactive iodine was recommended. So if you had gross extrathyroidal extension, if you had, distant metastasis, if you had a really large tumor, radioactive iodine is recommended. It's not recommended if you have a microcarcinoma, so what we talked about earlier, even if it's multifocal. And then there's all these individuals where there's conflicting data and the guidelines said selective use. So this selective use is sort of the epitome of when there should be shared decision-making. And so we specifically wanted to focus on those individuals who had thyroid cancers where selective use of radioactive iodine was recommended. And so again, we started with the entire cohort. We excluded those who did not receive total thyroidectomy because these would not be candidates for radioactive iodine. And we excluded those where radioactive iodine is not recommended, so microcarcinomas, or is always recommended, so the distant mets, the really large tumors, the gross extrathyroidal extension. So we ended up with this study sample where selective use of radioactive iodine would be recommended. And then we asked the patients about receipt of radioactive iodine. And I have to say, we also reran it looking at receipt of radioactive iodine based on SEER data, and the findings are the same. But as you can imagine, receiving radioactive iodine tends to be memorable. And so we sort of spelled it out. We asked them that if they, we said they might remember getting a low iodine diet, becoming hypothyroid, getting a shot of thyrogen in their butts if there wasn't hypothyroidism induced, seeing a doctor who gave them a radioactive iodine pill or liquid, And did they receive radioactive iodine? And there was high correlation between what the patient said and the SEER data. And then the findings were very, very similar if we did it with patient report versus SEER data. And so we used patient report. Key was we asked them if they felt they had a choice about whether or not to receive radioactive iodine. So again, these are individuals where selective use is recommended, so they should have a choice. And then we asked how strongly the doctor recommended the radioactive iodine. And we used a Likert scale from strongly against to strongly recommending. And then we wanted to know about decision satisfaction. So how satisfied were they with the decision? And again, we used a Likert scale from not at all to totally satisfied. And so what was impressive was 76% of the sample received radioactive iodine, and 56% reported not having a choice about receipt of radioactive iodine. So this is concerning. So it's over half that felt they didn't have a choice. The physician was very influential. So 95% of those whose physician recommended it received it, versus 23% if their physician recommended against it. And 85% of those who perceived they did not have a choice received radioactive iodine, compared to 68% who felt they did have a choice. And so here's the multivariable analysis. So you can see when we control for everything else, not having a choice is associated with increased likelihood of receiving radioactive iodine. And the star is because the physician recommendation is actually really powerful in this analysis, so it has a very high odds ratios. And you can see if they have lymph node mets, they're more likely to receive it, and that makes sense. And then there's some slight differences based on education as well. And when we looked at satisfied, you can see that those who did not have a choice were less likely to be satisfied with their treatment decisions. Not surprisingly, when we put side effects into this, those who had side effects were less likely to be satisfied with their treatment decisions as well. And you can also see that there's a difference based on age. And then when we looked at those who did not have a choice and amount of information they felt they were provided and level of involvement, you can see that those who didn't feel they had a choice were less likely to say they got just the right amount of information or had just the right level of involvement. So in summary, many patients did not feel they had a choice about whether or not to receive radioactive iodine. And again, this is concerning because of the cohort that we selected where there's selective use. And patients who perceived they did not have a choice were more likely to receive radioactive iodine and report lower decision satisfaction. And so this just really emphasizes the need for more shared decision-making to reduce overtreatment. So we dived into the patient and diagnosis, the patient and treatment. And I'm very interested in survivorship. And so we wanted to go a little deeper with patient and the survivorship period. And so this is not from our survey, but from a prior study where we found that there's been increased use of imaging. And we found that the more you image doesn't necessarily lead to better survival. So you do pick up more recurrences, or at least treatments for recurrences is more if you image more. But with the exception of radioactive iodine, which we presume is for iodine-avid disease, more imaging does not correlate with better survival. And so how do patient preferences affect thyroid cancer surveillance intensity? And so I previously heard a lecture by Jerome Grootman and Pamela Hartzband, and they wrote this interesting book about your medical mind and the idea that some of us are maximizers, some of us are minimizers, and we can have the same knowledge, but we may have different preferences based on this maximizing and minimizing tendency. And this is both for patients and physicians. But this really struck a chord with me because I have many colleagues who may have identical knowledge, but may have more maximizing preferences than me, or vice versa. And so we wanted to focus on the patients. We worked with Laura Schurer, who's now at the University of Colorado, and she took this concept that originated from Grootman and Hartzband, and she created a validated scale. So this has been tested, but in paid patients, not in patients who are actually making a medical decision for their illness. And so we wanted to test it in individuals who've made medical decisions for their illness. And so this is the validated maximizer minimizer scale. You can see it has things like it's important to treat a disease even when it does not make a difference in survival. If I feel unhealthy, the first thing I do is go and see the doctor and get a prescription. So there's various questions in here that are part of the scale. And so we started with our entire cohort, and we excluded those with recurrent, persistent, or metastatic disease because I'm getting ready to look at use of imaging. And so these are individuals who may have clinical reasons to have more imaging. We excluded those where we didn't know their disease status or where their stage was unknown. And so we had over 2,000 patients. And you can see this is where they fall on the maximizer minimizer scale. So if we just split it right down the middle, it's 40. And if we split the other, 40 to 70 down the middle, it was 55. And so we just divided it into minimizers, moderate maximizers, and strong maximizers. You can see the scale's a little bit skewed. This is thyroid cancer patients. And so I don't know how this compares to the population at large necessarily, but within this cohort of thyroid cancer patients, this was the distribution on the scale. And so then we want to know about healthcare utilization. So thinking about the most recent year, how many total doctor visits did you have for thyroid cancer? For the most recent year, please mark the type and number of imaging tests you had for your thyroid cancer. So these were the questions that we asked. And so what is impressive here is there is clear differences based on if you're a minimizer, a moderate maximizer, or a strong maximizer. And so this is showing sort of the extremes, people that reported 4 or more doctor visits a year, 2 or more neck ultrasounds a year, 1 or more radioactive iodine scan, 1 or more other imaging. And just to be clear, these are individuals who are about 3 years after diagnosis. So this is not the first year. But you can see this pattern of the stronger maximizer you are, the more imaging, the more doctor visits. And this is our ordered logistic regression analysis with cumulative legit for doctor visits, neck ultrasound, radioactive iodine scan, and other imaging. And for each of the analysis, we controlled for age, sex, race, ethnicity, comorbidity, AJCC 7 stage, and SEER site. And so if you look at the strong maximizers versus minimizers, which is the first column, you will see that across the board, there's significant differences. If you look at the moderate maximizers versus minimizers, it's not across the board necessarily. There's some that are not significant, but there is association you can see with neck ultrasound, for example, with other imaging, with 2 or more radioactive iodine scans. So there is a difference with the moderate maximizers and the minimizers, and then marked differences with the strong maximizers versus minimizers. And so just showing this idea that your preferences do make a difference, and the patient is influencing their care. So more care is not always better care, especially for thyroid cancer surveillance. This patient preference for more maximal versus minimal approach is associated with increased number of physician visits and imaging tests. And so there is a need to consider this maximizer minimizer tendency when we frame discussions on surveillance. And then something that really interests me and my group is the psychosocial impact of thyroid cancer. And so I want to talk a little bit about worry and cancer-related worry. And so again, this is during the survivorship period. We excluded individuals with recurrent, persistent, and distant disease because these are individuals that we expect may have some worry. So we're looking at those that are disease-free and they're 2 to 4 years post-diagnosis. And so even in these disease-free individuals, 41% reported worry about death, 44% worry about harms from treatment, 55% worry about impaired quality of life, 58% about family at risk, and 63% are worried about recurrence. So recurrence is the number one worry that our patients are having. And for those of you who treat thyroid cancer patients, I think this may not be surprising. A worry is very prevalent. We have a lot of young patients, and this can often be an issue. This is looking at each of the specific worry. So again, we're controlling for multiple variables. These are several analyses, but you can see patterns here. So females a little bit more likely to worry, not on every item, but some. You can see, for example, family at risk. You can see that there's a difference by age. So younger individuals more likely to worry. And again, non-Hispanic white is less likely to worry than some of the other minority cohorts, including Hispanic and Asian. And then, not surprisingly, there is more worry for those who have a history of lymph node mets from several of the issues. And this worry does have impact. So what does it mean? What happens with worry? And so if you look at this figure here, The gray bar is the level of worry that they reported they first had at time of diagnosis. And so we expect that to be high. And you can see that, over 85% report that they're feeling upset. Close to 50% report that at the time of the diagnosis, they're feeling distant from family and friends. And over 60% report that it's affecting their daily activities. And so that may not be surprising, but I think what's bothersome and something that we ultimately need to address is that this 2 to 4 years after diagnosis, there's still a large cohort who have worry. So 25% are saying that worry makes their daily activities difficult. Over 20% are saying it makes them distant from family and friends. And you can see here, closer to 40% report that they're feeling upset. And this is 2 to 4 years after diagnosis in individuals who are disease-free. And so I think this is a major concern and something that we as clinicians need to figure out how to address better. And we received supplemental funding from the NIH to do a follow-up survey of Hispanic women. It was thought by the NIH that this group was underrepresented and understudied, and that this was an important area. And so we wanted to see, how does worry change over time? So we had an 80% response rate when we surveyed Hispanic women from LA. And what you can see in this bar graph here is worry over time. So the dark gray, the darkest shade, is high worry at 3 years that remained high at 4. And then the next shade of gray is low worry at 3 years. And then these individuals reported high worry at 4. And then the lighter shades are for individuals that their worry was either low initially or it became low at time 4. So you can see that there's many patients who are doing well, which is great. They don't have worry. But on the flip side, there's a substantial number of individuals who have worry, and it's either persisting over time, or in some instances, it's getting worse over time. So in summary, with our patients, we found out that cancer-related worry is very common, even in these disease-free patients. It can persist for many years. So we're looking at individuals 3 and 4 years after diagnosis. And so patients need to be informed about resources to help with worry. And when we come to the physician section, which is next, I will talk about what are physicians doing to address this worry. So the patient is important, and so we loved it that we got this rich, deep information about the patient. But what about the treating physician? How important are they? And so we're going to talk about the physician. And so what we did that was kind of exciting for us is that we were able to ask the patients, who is the surgeon who treated you? Who is the endocrinologist who provided your care? Who's the provider other than the endocrinologist and surgeon who provided your care? And we also were able to check this information with the SEER sites. So they would have a lot of this information as well. And so then we surveyed the surgeons and the endocrinologists. They got an identical survey that treated these actual patients. And then we went to those, they said, when we asked who's the other physician who treats you, if they were nuclear medicine, we would exclude them. But if they were a PCP, we kept those list of names and we surveyed those PCPs. So, and they got a separate survey. Some of the questions were overlapping and identical to the endocrinology and surgeon survey, but some of them were very different. And so we were really happy from the surgeons and endocrinologists. We had a 69% response rate, so really robust. And from the PCPs, we had a 56% response rate. And so we wanted to ask the physician about diagnosis. So we found out about the patient that ultrasound is contributing to an increased diagnosis of microcarcinomas. So what do the physicians say? And so first of all, going back to the patients, and sort of something I think is important in our research moving forward, is we asked the patients which physician diagnosed their thyroid cancer. And so interestingly, 41% of patients reported being diagnosed by a surgeon, 38% by an endocrinologist, and 14% by a PCP. And the reason I say that this is important is, yes, the majority of these diagnoses are coming from surgeons and endocrinologists, but PCPs are involved. And so we need to include them in our future research as well. And we found that compared to non-Hispanic white patients, patients who were Hispanic and Asian were more likely to be diagnosed by a PCP and less likely to be diagnosed by a surgeon. So really influencing their care is the PCP. This may be related to the physician-patient relationship that they have that's pre-existing and their comfort level, but it still emphasizes that PCPs need to be involved in our research and when we disseminate guidelines that we need to reach PCPs. We wanted to find out about physician use of ultrasound. So if ultrasound is contributing to overdiagnosis, why are physicians ordering ultrasound? And so this is one of the questions that was in the PCP survey, as well as the one that went to surgeons and endocrinologists. And so we asked them to select all of the reasons that they would get a thyroid or neck ultrasound. And what you can see in this bar graph here is we then divided it up. And you can see that the majority would get it for things that most people would think are clinically supported. So if there's a palpable thyroid nodule, a large thyroid or a goiter, a nodule seen on another imaging test, there's new onset hoarseness or compressive symptoms. Those are reasons that many of us would get ultrasound. Whether or not to get an ultrasound if there's a family history of thyroid cancer or a history of head or neck radiation is really unclear. And so we weren't surprised that it was about 50-50 on who's getting an ultrasound in those situations. But what we're interested in is item C here. So you can see that some ultrasounds are reportedly ordered for patient request. And I think all of us have had moments where, we try to make the patient happy and we get a neck ultrasound, but downstream of that, there may be some negative consequences. And so it's tricky, but we have to consider that. You can see abnormal thyroid function tests are a reason that some physicians, over 25%, said that they would get an ultrasound. And this is troublesome. So we know the Choosing Wisely guidelines do not recommend ultrasound for abnormal thyroid function test. And so this is a concern. And then positive thyroid antibodies. So over 20% would get an ultrasound for positive thyroid antibodies. And again, there's no data suggesting that that's appropriate. And so physicians are using ultrasound, and for some of the reasons, they're not clinically supported. And so again, I think this is important just because it gives us a target if we want to make a change, things that we could potentially address. So understanding which physicians are involved in thyroid cancer diagnosis is critical for dissemination of guidelines and for targeted interventions. Physicians report use of ultrasound for reasons not supported by clinical guidelines and in conflict with Choosing Wisely. And so to reduce overdiagnosis, we need to discuss optimal use of neck ultrasound. And what about the physician and management? And so we have done quite a bit in this area. I'm going to talk first about TSH suppression and then about radioactive iodine. We've also done stuff on surgery as well, but I'll focus less on that today. So TSH suppression, we know for high-risk differentiated thyroid cancer patients, it can be beneficial. But current guidelines recommend against TSH suppression for low-risk differentiated thyroid cancer patients. And so again, in our survey, we had vignettes. So sometimes physicians will argue because they'll say, oh, my patients at the University of Michigan are different from your patients at the Mayo Clinic. That's why our care looks different if you look at big databases. But we wanted to use vignettes where there'd be standardized patients that everybody was seeing. And so we had an intermediate risk individual, which is a 55-year-old woman with a 1.5 centimeter classical papillary thyroid cancer, microscopic extrathyroidal extension, and one positive lymph node. Low risk, so a 65-year-old woman with a 1.5 centimeter classical papillary thyroid cancer, no extrathyroidal extension, no invasion, no lymph node mets. And then someone that we would all agree is very low risk, a 40-year-old woman with a 0.9 centimeter classical papillary thyroid cancer, no extrathyroidal extension, vascular invasion, or lymph node mets. So we had vignettes where all these physicians are seeing the exact same patient, and we're asking them about management. And so if you look at the bar graph here, the good news is the lower the risk of the patient, the less likely the physician is to recommend TSH suppression. And so that is good. There is difference. The thing that we'd like to improve is you can see that for low risk and very low risk in particular, there's still a substantial number who are receiving TSH suppression where it's probably not necessary, and even some of the intermediate risk, to be honest. But you can see for the low risk, about 50% are still recommending TSH suppression, and for the very low risk, it's over 25%. And so this is concerning. It's putting patients at risk for osteoporosis, for arrhythmia. In multivariable analysis, we found that surgeons were less likely to recommend TSH suppression for intermediate risk patients. And then we found that volume plays a role. So we always knew that volume played a role for surgical management, but this is showing for medical management as well. So physicians with higher volume were less likely to suppress TSH in low or very low risk patients. And physicians who estimated a higher likelihood of recurrence were more likely to suppress TSH in very low risk patients. So this gets at knowledge More understanding about risk of recurrence may help curb some of this treatment. And then this issue with volume is very important, is reflective of what we've seen in surgery as well. What about radioactive iodine and shared decision-making? We said that some of the patients felt they didn't have a choice. What about when we talked to the physicians? And so this was actually one of our most complex studies. We wanted to look at the interplay between physicians and patients. And so what we did is we merged the physician survey data with the patient survey data, creating patient-physician pairs. But some patients may be more than one pair set. So if they had a surgeon and an endocrinologist, there'd be 2 pair set. And so we had 2,661 patient-physician pairs. And this just shows how we created the pairs. So again, it was really complex. And we did a multivariable weighted logistic regression, and we accounted for the clustering of the patients within the physicians. So we clustered the patients below the physicians. We accounted for the physician characteristics. And then we took this vignette that I showed you that had a low-risk thyroid cancer patient to look at sort of what was the physician's preference for use of radioactive iodine in that setting. We looked at practice setting, number of patients with thyroid cancers seen per year, specialty. We also had patient characteristics that we included as well. And so the key results were in this physician-patient relationship, the physician really plays a major role. And that may not surprise you. So physician propensity to use radioactive iodine based on the vignette was associated with patient receipt of radioactive iodine for low-risk thyroid cancer. So the physician is a major player in the decision-making process. And again, volume came up. So seeing more than 40 thyroid cancer patients per year was associated with less use of radioactive iodine for low-risk thyroid cancer. So although patient decision aids exist, we think this study is important because it shows we need more than that. It's not just about the patient. We need future interventions that incorporate both the patient and the physician. And then, as I mentioned, the psychosocial impact of thyroid cancer is really important to my team. And so we wanted to know more about patient worry. And this is one of our older studies. So this was a survey of physicians from a different cohort. But even back then in 2013, we found that physicians were reporting that their own worry about patients, as well as patients' worry, was contributing to whether or not a patient receives radioactive iodine. And then this is from our more recent physician surveys. So again, these are endocrinologists, general surgeons, and ENT doctors. And we wanted to understand, how do they manage worry? Do they recognize their patients are worried? And they do. So 65% said their patients are quite or very worried, 27% somewhat worried, and just 8% said they're a little or not worried. And they recognize that it impacts care. And so if you look at these bar graphs, the dark gray is often a lot, the medium gray is sometimes, and the light gray is never or rarely. And so you can see that patient worry, physicians will report, is increasing referrals, laboratory work, imaging study, clinic visit number, and then especially clinic visit length number. And for those of you who see thyroid cancer patients, I think that some of this is not surprising, but it is nice to be able to quantify and to realize it's not just your patients who have worry and it leads to more longer clinic visits. It's happening for everybody. And then you can see that they also say that at least sometimes, and then you can see in some circumstances, often or a lot, this patient worry is leading to increased surgical or medical management. And so again, patient worry is impacting care. It's something that we need to figure out how to address. And so we asked physicians, what are they doing to address it? And I think the take home with this figure is that physicians are putting a lot of burden on themselves. So physicians are making themselves available for further discussion, which is great. But maybe there's a role for other support as well. So you can see some refer patients to educational websites, not all. Some encourage them to talk with family and friends. Some refer to support groups, but not very many. And then very few refer patients to counselors. And so I think worry is impacting patient care. And we recognize that as physicians, but we need to figure out probably better ways to handle it or to help patients self-manage their worry. So in summary, from diagnosis to management to survivorship, patients and physicians work closely together. They're involved in the care process. And so when we think about future interventions, we need to think about that. Understanding current practice patterns as well as patients' and physicians' knowledge, attitudes, and beliefs is critical for improving care. So even though my team loves to work with big databases, we think it's also important to take this deep dive and understand the perspective of the patients and the physicians. And as I mentioned, future interventions need to focus on both the patient and the physician. So they're both involved in the management process, the decision-making process, and even in survivorship care. And so I just want to thank you. This is my team some of my team from the University of Michigan. I'm fortunate to work with a really talented, fun group of individuals, and it's part of what makes my research so exciting. And so thank you. At this point, I'll turn it over to you, JP.
Thank you, Megan. Fantastic presentation. We appreciate it. The audience, feel free to send us our questions. We will put them into the chat, but I will be the one reading them. Megan, I will start with a few of my own, if you don't mind. I think this was a very nice overview of your research, which has been fantastic. There is one aspect of care that I wanted to ask you in regards to the triggers of overdiagnosis. You did mention the couple of those, which is the ultrasound. And every time that I'm thinking about the ultrasound, I'm thinking why people order the ultrasound. And you mentioned items that might not be related with clinical practice. But every time that I think about it, it makes me feel that the ultrasound is actually the consequence of something else. And every time I see what is the trigger, actual trigger, it tends to be mostly the physical exam. And I find myself in a difficult situation because not only I think that the ultrasound is sometimes important, is that the physical exam now becomes a little bit of a diagnostic test that is so imperfect that drives the use of the ultrasound. And then instead of thinking about the ultrasound, I start thinking that should we be doing physical exams? 30 or 40 years ago, it was easy, patient had symptoms, palpable mass, you did a physical exam, the biopsy, that whatever you can palpate. Now, you don't have to be sure about the physical exam. You feel something lumpy, but you have the ultrasound at bedside. So it seems that now these two elements of care, physical exam plus ultrasound, come together. And as you are aware, the US Task Force actually recommend against physical exam in patients with no symptoms. And yet, physical exam is such an important element of care. So I'm not sure, to be honest, what to think about this. I'm still, as a researcher, as a clinician, without a clear pathway. But every time I think the ultrasound, I think about, should we start doing physical exam in patients with no symptoms whatsoever? What are your thoughts about it?
Yeah, so that is an area. One time I was giving a talk and I brought up the Choosing Wisely guidelines, mentioning that, or sorry, the United States Preventive Task Force mentioning that. And there was a lot of uproar from endocrinologists. So it was, most felt very strongly, yes, we should do less ultrasound. We should not abandon the physical exam. And so, that was sort of the feel that I got from the room at the time. But I have to say, our study did show that some of these patients with tumors less than a centimeter had reported that their physician palpated it. And so, the likelihood that was palpated, unless it's really anterior on a very slim neck, is low. And so what are they actually palpating? And so it was sort of interesting that there was no difference in those that, said it was picked up by their physician on exam who had a sub-centimeter nodule versus a larger nodule. And so I think that sort of is what you're talking about, that we're sometimes feeling things that aren't really a thyroid nodule, but then we do an ultrasound and then we find something small that's probably unrelated to what we palpated. And so I think that is contributing. And on the other hand, we don't want to miss big things, but a lot of times it depends on the neck. Sometimes those are visually obvious, and then you see it on the patient and then you palpate it, but the patient might have reported that it was palpated, but you saw it when they walked in the room. But yeah, I think that it's controversial. I lean towards that we need to figure out, so understanding these pathways, how individuals get there, I think is key. And then understanding which are the individuals that have bad outcomes is key. how many of those were actually incidental findings versus how many of those with poor outcomes, were picked up a different way. And so I suspect that in another 15 or 20 years, we're going to be saying that we should not do physical exam, but I think that we need more data first. And I think that there needs to be buy-in from patients and physicians. And I don't think that buy-in is coming soon, but I think with more data that there might be buy-in.
Interesting. No, I agree. Megan, there are a couple of questions from the audience. The first question has to do about the maximalist and minimalist scale. I think it was quite interesting to see that such a scale exists. So the question is, how do you feed them? At what point do you feed these patients within the scale of minimalist and maximalist? Is that useful in clinical practice? And is this something that patients change across the continuum of care? Meaning, it might be that a patient is maximalist, but as soon as they see the clinician talking about the options, they become minimalist, depending on how good the relationship has been. So what are your thoughts about something like that being deployed, and what time it should be deployed, if has any kind of practice implications, and how much of that can change over time in the continuum of care for patients?
So there were multiple great questions in that. So we administered it was about 3 years post-diagnosis in our thyroid cancer patient cohort. And this was the first time that it was used in actual, patients who are facing a medical decision. So it had been used in like paid patients before. The thought is that it's constant, meaning, the belief that you tend to be a maximizer for all medical situations, or you tend to be a minimizer, but for all medical situations. But we don't actually know that, because people haven't been tested at multiple points of time. It's hard to get someone before they got a cancer diagnosis and then after, because you don't know that they're going to get a cancer diagnosis. What we thought was interesting, that it was a little bit skewed, as you could see as well, and it's thyroid cancer patients. And so we also don't know, did we have a few more maximizers because thyroid cancer patients may be seeing their physicians more because they're maximizers? You know what I mean? Is that scale skewed just because it's a thyroid cancer cohort? Could it be that after their diagnosis, if there is a change? We don't know that. But the general thought is that we tend to it tends to be intrinsic to who we are, and that it sort of would carry through before you had your diagnosis and after. That's the general thought. The thing that's really interesting, there's not a validated scale for physicians. So I could take the scale, but the questions you can see are more reflective about what I would do as a patient. So does what I would do as a patient, align with what I also would tell my patients to do? Like, we don't know that, one. And then I think what would be really interesting, I suspect that both the patient and the physician, their maximizing, minimizing tendencies are influencing care. And if you get a maximizing patient and a maximizing physician versus a maximizing patient and a minimizing physician, maybe what care they get is influenced by the physician. I would guess that the physician sort of influences that, and maybe they do get less. Or maybe they choose a different physician. Maybe they're ones that are like, yeah, that's not the physician for me, and they identify a maximizer to provide their care. So I think that the maximizing, minimizing is fascinating, but that more work is needed in regard to how to use it sort of in the care setting. And I think more work is needed to understand physicians. When we got that funded by the NIH, a reviewer question is, how malleable is it? Right? And I think that was like a valid question. And, and so we emphasize how knowledge is malleable. We think that maybe some of this would be malleable, but we don't know. But I think that those are all like fascinating questions.
And I would like to, and I think that makes sense. We have been always impressed by sometimes how patients think before the encounter. So for instance, a patient might be, I want everything done. But depending on how the clinician addresses the problem in the encounter, that is quite flexible. Because, imagine a patient that goes to the encounter, let's put it in a different case, a patient with breast cancer that says, well, I want to preserve my breast, I don't want surgery. That's of course a goal, is more a minimizer. But once they go to see the doctor and say, the alternative here is this, because this is a way to extend your survivorship, that changes a lot your perception about what is needed, and it changes a little bit whether you are a maximizer or minimizer. So I agree. So I think there might be some flexibility that happens in interaction. And that would be fantastic to uncover that, perhaps with, studying these video encounters or encounters of patients and clinicians. So I think this is a fascinating topic. There is a question about pathology. You did not address this, so let me frame this perhaps in a different way. So there is research that suggests that we're not good clinicians. We're not good at predicting risk, even though we have the variables that says this is a low risk, intermediate risk, high risk patient. And that might be a driver of utilization. So we perceive that these patients might be higher risk than actually is. And a little bit of that maybe alludes to the question that there is a lot of variability in how sometimes studies, assess this risk of recurrence based on some pathologic features. One of those extrathyroid extension, minimal extrathyroid extension, microscopic. So this was something that at one point was considered intermediate risk, and now it's considered mostly low risk. But that continues to change. So new publications now saying maybe it's intermediate risk. So from the clinician's perspective, getting this signal of this might be intermediate risk, low risk, it might, I think, drive a lot of decision making. So the question of the audience is, what do you think about this positive microscopic extrathyroid extension in regards to whether this patient is low risk or intermediate risk?
So I'll answer this in two parts. So one, right now, I manage my patients aligned with the guidelines. So I treat it like the microscopic extrathyroid extension is low risk. But the caveat is that if you look at the data, we have good survival data, and we know we can risk stratify for survival pretty well. Most of our patients are going to do well. Our recurrence data is not as strong. And so large databases like SEER, the NCDB, they don't capture recurrence well. And so then you have a lot of small single institution studies, but then it gets a little tricky, right? Because the patients that are seen at Memorial Sloan Kettering may not be the same as the patients that are seen in the community. So you don't have that big population-based data looking at recurrence and recurrence risk factors. And so I think I think you're exactly right, that all of us sort of question, who is really low risk, because we know that data isn't quite as strong as the survival data. And so I do think that's an area that we need more work, because I think there's very good evidence that there's more guideline concordant care once you have higher quality data. I think in general, that's where we're lacking in the thyroid cancer world. There's not a ton of NIH funding and big studies on thyroid cancer. And so the data isn't that strong for a lot of things. And so when the data is not strong, you have that ambiguity. I think you have more variability in the care that patients are receiving, because there's that element of uncertainty.
Absolutely. Another question from the audience has to do with the study that the survey about ultrasound use for physicians, and the ones that said not clinically indicated. One of those items have to do with thyroid dysfunction, and I think it's whether this is hypo or hyperthyroidism. I have seen that physicians and clinicians agree with the fact that hypothyroidism by itself is not really an indication for ultrasound, but hyperthyroidism, depending on the circumstances, actually might become a clear indication for ultrasound. So do you have that distinction in your research, and what are your thoughts about the use for thyrotoxicosis? There are different types, but certainly, how do you conceive that as a good use or bad use?
Yeah, so we purposefully kept the wording similar to what it was in the Choosing Wisely guideline. So we just had like abnormal thyroid function test, which is broad, really broad. And you could see it was like a high percent, I think it was around 25% that said that they would get it for abnormal thyroid function test. Maybe some of them were thinking about if someone is hyperthyroid and they had an abnormal radioactive iodine scan that had like a hypopenic area, maybe then they're getting the ultrasound, perhaps. But the way we worded it was just to be aligned with the Choosing Wisely, where it's typically not recommended for abnormal TFTs.
Yeah, and in our research, we have seen that when the ultrasound for thyroid toxicosis was already in the setting of endocrine care, so specialty care, it tends to be in the setting of trying to understand amiodarone kind of induced hypertoxicosis. So there is maybe nodular versus non-nodular version. When it was used from primary care setting, was mostly inappropriate because it triggers just a cascade, something is abnormal in thyroid. So I think there is an important distinction of the intent, and I think that's a very good question. Very good. One thing I've seen happening in the field, and I would love to see your thoughts, is that we put a lot of emphasis in overtreatment as a way to correct some of the cascade of events. So, active surveillance, radiofrequency ablation, trying to do short decision-making to avoid the overuse of radioactive iodine, trying to do lobectomy instead of total thyroidectomy. But I find those efforts, although needed, very difficult because you are at the end of the cascade when you already find, in your own words, maximizers that will be very unlikely to take on conservative strategies. The opposite of that, or alternative to that, is actually to work in the upstream, to work in the overdiagnosis piece, start thinking about the ultrasound drivers, the physical exam, all that kind of stuff. Yet our field is really lacking a lot of research in that particular area. It seems that we were focusing mostly in the downstream. That's really difficult to tackle with, but we haven't been working a lot and to avoid finding the nodule to begin with. Mm-hmm. So what are your thoughts about that? How's the new guidelines, for instance, taking on this challenge?
Yeah. So my personal thoughts are that both are really difficult. So I think the overdiagnosis is tricky too, like how to get people to image less. Because some of these are incidental findings. Someone comes in for neck pain in the ER and they get a CT scan and thyroid nodules noted. So I think that the overdiagnosis aspect can be difficult as well. And we did, again, we tried to lay the foundation for like who's getting these ultrasounds and why. And so I do think there's some targets, as I mentioned, some are being done for things that we would think would be clinically appropriate. Reasons may still lead to diagnosis of small cancers that don't benefit the patient in having them detected. But I think there are some like low-lying fruits that can be targeted to overdiagnosis in. I think it's multifactorial. So I think that it needs multiple targets, so I think that you can't just target the overdiagnosis, you have to target the overtreatment too. And then we're just going to be able to decrease it, not to zero, but decrease the amount of people that are getting like inappropriate diagnosis and treatment together. So I think that there's room and there's some low-lying fruit and then some more complex things that we can target at all ends of the spectrum. I do think that when you compare our cancer to, let's say, prostate cancer, something that makes it trickier for our cancers, our patient cohort is so young, so it's, I think it's easier to say, let's do less, when you're dealing with someone who's in their 70s versus let's do less if you're dealing with someone in their 40s and we don't know how long to follow these individuals. Is it for 10 years? Is it for 40 years? So I think that becomes complex as well. So I think there's some nuances to thyroid cancer that especially make it difficult when we're trying to decrease overtreatment and do sort of more active surveillance or something that's like more minimal.
Absolutely. I think your research uncovered one of the probably most important aspects of healthcare delivery in thyroid cancer survivorship care is the role of primary care providers. I think you, in addition to this publication, you also have uncovered how often these patients are seen by PCPs, particularly, for instance, Hispanics. They are diagnosed by PCPs and likely managed by them. Yet, they are not in our meetings. They don't read our guidelines. So it seems to be that there's a significant gap now that we're finding more and more thyroid cancers, and we are in a shortage of endocrinologists, ENT, endocrine surgeons. The bulk of the volume of these patients will be transitioned up front or even in survivorship care to PCPs. What are your thoughts about how should we tackle this as a clinician or researcher?
Yeah, so I strongly agree with that. And I think sometimes we are at fault for just communicating with each other And we make these great guidelines, but they're like 96 pages, and it's hard even for a thyroid cancer expert, right, to have the time to read that, much less like a PCP who, sees multiple different conditions. And so I think that we need to do a better job at incorporating the PCPs, one, and then two, communicating with them. Like I've talked with a lot of PCPs who would love like a one-page, what do I need to know about diagnosis, about treatment, and about survivorship, and again, like the complex patients, they probably shouldn't be referred to the PCPs, but we have a lot of low-risk patients, after the initial 5 years, 10 years, maybe they need to be seen by the PCPs, similar to what happens with other cancers. And so I think that there's really an opportunity for us as a group, meaning like the endocrinologists, the surgeons, to sort of work on involving the PCPs, communicating with the PCPs, and making like a clear like transition plan for when patients should transition to the PCPs. But you're absolutely right. Some of these patients have a good relationship with their PCPs. We're the new doctor that they don't know. They have a longstanding relationship with their PCP. They trust their PCP. And so I think that we need to build on that, not sort of alienate the PCP and not communicate with them.
And I appreciate that answer. I think this is certainly an area that we need to work more. You mentioned many times the role of patients' preferences, how patients feel about this, the worry level. Clinicians are part of this too. Together, they make sense of a difficult situation. How do you suggest or what kind of interventions exist to do shared decision-making in patients with thyroid cancer? And if no intervention exists, what can you advise to the audience, which is mostly clinicians at this point, or surgeons? How do we do that, particularly when we are restricted by the time that you have to see patients?
Yeah, so I think the time restriction is a major problem. So there are decision aids that exist for patients, especially surrounding radioactive iodine. I think with the patients and physicians and shared decision-making, a key thing is that we should tell our patients they don't have to make a decision today. So for thyroid cancer, most of these things are not urgent. We can provide them reading material. We can make sure that we provide things in a form that they like some patients are more visual, some like numbers, some don't like numbers. We can make sure that we meet them with a method that they like. And then let them know that they have time to talk to their family members, they have time to consider it, and then they can make a decision. I think sometimes patients feel like they need to make a decision in the office. And for thyroid cancer, that's rarely the case. So I think that we should realize that patients have time, give them time to think about it. We should provide material, in a method that they like, whether it's written, whether it's, through a support group, whatever we think is sort of a reliable source. And then I think, sort of a tangent, but I think we also have to have language concordant tools available, because I think that's where it gets really complex is when we have translators involved, suddenly that 15 minutes is definitely not enough time with the patient. And so I think we have to make sure that we have resources available to those individuals as well.
Absolutely. And in fact, what you mentioned previously, just the fact of patients knowing that they have options, just how powerful that might be, just for them to know that there is more than pathway to move forward, I think might be quite a predictor of how that conversation will go. But Megan, this has been fascinating. I can just keep asking you questions for hours, but we are up to the hour, and we would like to thank you for your wonderful presentations. I will thank the audience as well for their wonderful questions too, and invite you to join to our ongoing virtual series next Friday. Thank you, Megan.
Great.
Appreciate it.
Thanks so much. I appreciate it.